Okay, so I think we're going to get started. Good afternoon, everyone. My name is Lillian Lin, and this is my co-chair, Chi Guan of Research Day. Welcome to the final session of Research Day 2020, which will feature a keynote speech from Dr. Jodi Sherman, followed by our annual IHPME Awards ceremony, which will be delivered virtually for the first time ever. We hope that you have enjoyed today's event so far and found them to be both informative and inspirational. As our Research Day theme this year is climate change and sustainable health systems, we hope that you may take away from this year's program new ways of thinking around how to embed environmental sustainability into the healthcare sector, as well as into your own work, research, and professional lives. Personally, I'm very thrilled by our stellar lineup of panelists, and I very much look forward to Dr. Jodi Sherman's keynote speech. Before we get to it, Chi and I, Research Day co-chairs, would like to thank a group of individuals for their help with planning and coordination of today's conference. Dr. Whitney Berta, Dr. Aviv Shachak, Dr. Fiona Miller, Dr. Audrey Laporte, Elisa Kim, Zoe Downey-Ross, and the entire Research Day Planning Committee. We'd also like to extend a big thank you to all our speakers and panelists and moderators. So, just a little housekeeping for the session before we get started. This webinar is being recorded. If you have any questions during the presentation, please type them into the Q&A box. She and I will be monitoring the Q&A questions and we'll bring them up at the end of Dr. Sherman's presentation. Now I have the pleasure of introducing our keynote speaker for Research Day 2020, Dr. Jodi Sherman. Dr. Sherman is an internationally recognized researcher in the emerging field of sustainability in healthcare. She is an associate professor of anesthesiology at Yale School of Medicine and an associate professor of epidemiology in environmental health sciences at the Yale School of Public Health, where she also serves as the founding director of the program on healthcare environmental sustainability of the Yale Center for Climate Change and Health. She also serves as the medical director of sustainability at Yale New Haven Health. Dr. Sherman's research focuses on life cycle assessment of environmental emissions, human health impacts, and the economic impacts of drugs, devices, clinical care pathways, and health systems. She works to establish sustainability metrics paired with health outcomes and costs to help guide clinical decision-making, professional behaviors, and public policy toward more ecologically sustainable practices. Dr. Sherman routinely collaborates with environmental engineers, epidemiologists, toxicologists, health economists, health administrators, health professionals, and sustainability professionals. Dr. Sherman, now I will turn it over to you.
Well, thank you, Lillian and Chi, and also to Dr. Fiona Miller for this invitation. Can everybody hear me okay? Can you hear me okay? All right. Sorry, this first slide is cut off. So I frequently try to talk about this ironic problem of trying to prevent disease, but at the same time we are causing pollution. So it really is a challenge for us to first do no harm. Today, I hope that by the end of the talk, you'll be able to identify a relationship between healthcare pollution and disease burden, define what we mean by life cycle assessment, summarize some of the latest healthcare pollution findings, and identify opportunities for mitigation. For disclosures, the Yale Program on Healthcare Environmental Sustainability has received a non-designated gift from the Association of Medical Device Reprocessors, and they have no say in the content of my research or my talks. For those who do social media, my Twitter handle is @GreeningDoc, and some suggested hashtags are sustainable healthcare, clinical sustainability, net zero, and climate change. Some of you may be familiar with the planetary boundaries work, and what that work tries to do is define essentially areas within the biosphere that must work together, and to be able to understand how our system is functioning and dysfunctioning, and whether or not we're living within the bounds or the planet's ability to regenerate itself or not. And so, of course, we talk a lot about climate change. That's not the only consideration or concern. Climate change is closely related to ocean acidification, oceans being our primary fast sink for carbon dioxide in the atmosphere. There's also concern for biodiversity loss, where it's well recognized we're in the midst of the 6th great mass extinction. Air pollution is closely associated with climate change and also ocean acidification, because they're both related to fossil fuel combustion and so forth. And chemical pollution also being an area where it's gray here, because we can't, it's hard to define what the damage is in terms of planetary boundaries, but we know it's a severe concern. And so when we're outside of this green zone right here, we're outside of the planet's ability to regenerate itself. And obviously we can reduce a lot of our emissions, including in healthcare, but we don't want to reduce to the point where we don't have equitable access to the ability to thrive and live healthfully. And so really we don't want a shortfall and we don't want to overshoot. So what we're aiming for is the donut here. And that has been coined by an economist, Kate Rayworth, in Doughnut Economics. And so why sustainability in healthcare? Well, we know pollution is the leading cause of morbidity and mortality globally. 9 million premature deaths annually due to pollution, or 16% overall of annual deaths. And healthcare itself is a leading emitter of environmental pollutants, and reducing healthcare pollution can improve the triple bottom line. So engaging health professions and health professionals is a passion of my own around healthcare pollution, because I see it as a key for engagement, because everybody is touched by healthcare. And while not every health professional has the time to get involved with trying to green their health system and so forth, every one of them cares about how to do best for their patients. And so engaging health professionals around their practice is a way to touch every single citizen and also affect public policy, and I believe a key for societal transformation. And so I know everyone here is already an expert, but I think it's worth reviewing the impacts of climate change on human health. And I will say, even though there are these other dimensions I talked about in planetary boundaries, this talk will focus on climate change. And certainly we know that by increasing CO2 levels in the atmosphere, trapping infrared radiation, we're seeing rising temperatures, more extreme weather events, rising sea levels. And so severe related weather events, we're seeing increased physical injury, certainly mental health impacts. People are losing their jobs, losing their homes, having to move. Already mentioned air pollution. So air pollution being very closely related to greenhouse gas emissions, again, through fossil fuel combustion. And so we're seeing increased COPD, asthma, cardiovascular events, changing vectors of diseases, so more habitable ecosystems for a lot of these vectors. So things like malaria and dengue, their ecosystems are expanding. Things like Lyme disease, which started in my own state of Connecticut, and Lyme, Connecticut is now ubiquitous throughout North America. Chikungunya and so forth are expanding up through Central America. Increasing allergens, so more hot days, more allergen, more pollen or longer pollen seasons is also worsening COPD exacerbations. Water quality is impacted as we see more severe storms, for example. Salt water can get into and sewage both get into our drinking water and impact water quality. Obviously, we're seeing droughts which affect both water and food quality. And forced conflict. So drought, for example, in Syria was in part implicated with food insecurity that led to mass migration and political instability there. And so in terms of healthcare, so those are some of the damages we see from a changing climate. Also specifically impacting health systems or weather-related events, whether they're hurricanes, which are very common here at the Atlantic coast, and we've been very much personally impacted in my own health system in Connecticut. We're right outside New York City, so Hurricane Sandy very famously affected New Jersey, Connecticut, and Manhattan. You see staff famously evacuating neonatal intensive care unit at NYU Langone Medical Center that made national headlines because the whole city was flooded with salt water, and their backup generator was in the basement. And so the hospital that they largely evacuated to, including Bellevue Hospital, they had difficulty getting the fuel because the fuel pumps were down. So 3 days later, they also had to evacuate that. So a lot of disruption from weather-related events. And of course, you've heard of the fires, not only in Australia, but certainly in California. It's a big problem for us. Very famous campfires affecting Paradise and also Paradise in California in 2018. This was right outside the Adventist health system, facility that was evacuated and essentially caught fire shortly thereafter. So we're already seeing weather events disrupt our physical facilities and also our supply chain. So in the United States, it turns out that a lot of our drugs and also many of our devices are manufactured and often solely manufactured on the island of Puerto Rico. And Puerto Rico was devastated by Hurricane Maria in 2017, so that dramatically impacted our supply chain. So things that made the news were things like shortages of saline. Things that didn't make the news were things like shortages of local anesthetics. So my own profession as an anesthesiologist, you see here, this is actually a 2 ml vial of bupivacaine, which go into our spinal anesthetic kits. And we routinely do spinals for laboring mothers who have to have emergency C-sections, so for surgical deliveries. And because this vial ran out, we were substituting a 30 ml vial. And because of concerns for safety, for errors, for cross-contamination, lack of infrastructure for safely splitting these vials, we're ironically throwing away over 95% of the vials. So at the same time we had shortages, we're actually increasing drug waste. So part of the irony and challenges of our infrastructure. And so healthcare resource consumption, at least in the United States, us being an outlier, we know we spend twice as much as any other industrialized country in healthcare, including Canada. We're now past 18% of our GDP, but globally, healthcare is 10% of the global economy. And hospitals are very energy intensive, 2.5 times the energy requirements as similar sized commercial buildings. They run 24/7, have very high tech diagnostic and therapeutic equipment. We have this unique thing in our industry for infection prevention. There's, the only other industry that probably comes close is the food industry, but they don't have to be sterile at every step of the way that we do in many cases. So a lot of unique requirements around infection control. We have a regulatory complexity and also business models that are driving wasteful, unnecessary utilization of resources. So this complexity is well understood, but it's a big problem to deal with. And then particularly here in the US, I can't speak for practice in Canada, but we're probably not entirely dissimilar. We have a culture of excess and where disposability is normalized. And so globally, healthcare is responsible for 4.6 of global total emissions. So this is just coming from healthcare globally. And if you look at the left, you see per capita healthcare greenhouse gas emissions on the y-axis, and on the x per capita GDP, and the bubble is spend per patient. So the US is an outlier here. I already mentioned twice as much as any other healthcare system. Canada is not the worst offender, if you will, but it's certainly up there in terms of per capita greenhouse gas emissions from healthcare. And globally, this trend is going in the wrong direction. There is an outlier here, Greece, but we can't really look to them as the exemplar here because they suffered quite severely from the Syrian migration, from the Syrian crisis. And so we can certainly reduce our emissions by providing less care, and that's not the objective. The objective is to increase access and to have good quality care for everyone and do so sustainably. Sorry, wrong direction. So going back to the US health sector for a moment, this was a landmark paper that we'd done in 2016, building on the work of Chung and Meltzer, where we found that 9 to 10% of US healthcare emissions, national emissions, were coming from healthcare, and that this trend was increasing over time. If the US healthcare sector were a country itself, it would rank 13th in the world for emissions. We then looked at, we didn't just look at greenhouse gas emissions. I said this talk is mostly about greenhouse gas emissions, but not entirely. We looked at other standard types of pollutants and air pollution in particular, particulate matter, PM 2.5, and also ozone and criteria air pollutants, together result in loss of 614,000 disability-adjusted life years annually, as mostly from air pollution, but also from climate change-related diseases. These are not equally felt in all parts of the world and country, and so we tend to not be aware of this. But importantly, we said that this disease burden is similar in magnitude as the 44 to 88,000 deaths due to medical errors that were first reported by the Institute of Medicine's famous To Err is Human report in 1999. This sparked the entire patient safety movement, changed the lens through which we see healthcare administration, healthcare practice, and always at the forefront of everything we do has to be preventing harm from the care that we provide, so patient safety. So this landmark paper changed the practice of care. Entire institutions, for example, in the US, the Agency for Healthcare Quality and Research came out of that. And really what we're saying is that pollution-related disease burden from healthcare is in the same order of magnitude. So roughly 10 years of life are lost from these premature deaths. And so if you multiply by 10, you see we're in the same order of magnitude. So really we've been making the argument that pollution prevention is the new patient safety movement. We did a similar study in Canada. Obviously, you're a much smaller nation than we are. Nonetheless, still significant emissions. So 33 million tons of CO2 equivalents emitted annually from the Canadian healthcare sector, or 4.6% of your national total. That's just from greenhouse gas emissions. There's also other pollutants, so greater than 200,000 tons of other types of pollutants emitted annually. And for you, in Canada, the loss of disability-adjusted life years is around 23,000. And importantly, and similar with other studies, that the big categories of concern were hospitals and pharmaceuticals as the major contributing categories. Now, there have been several national studies since this paper has come out, but one of the things that we did is looked at the relative contributions of Canada, US, and Australia health systems, which at the time were the only ones that were published. And a couple of things. So firstly, we can feel confident in comparing the national totals as opposed to the relative contributions. We can say what's more or less, but it's just important to keep in mind that these national level studies use slightly different methods. So even though we see that 20% of Canada's footprint is coming from pharmaceuticals, in the US closer to 10, and Australia somewhere in between, slightly different methods. But importantly, pharmaceuticals is a big area of concern, and hospitals are big areas of concern, and medical devices as well. So the leading work, this was mentioned earlier today, is coming from the National Health Service in the UK. So looking at relative emissions, coming back to this concept of where the greatest emissions are coming from. Importantly, coming from building energy, travel, and also there is some conversation about metered dose inhalers, and my own specialty, inhaled anesthetics, contribute a lot here. And so some of this can be addressed with things like telehealth, although we have to be careful with telehealth because we also increase emissions, right? Because we have more technology requirements, more energy requirements to support that technology. And at the same time, we can improve access with that technology. For example, people in rural communities who don't have easy access to specialists can increase their access through telehealth. When we see great social disparities, it can also decrease access or we see more health disparities. So we have to be, I do think telehealth is a good thing, but we have to be very careful in how we consider the benefits and weigh the downsides. But importantly here is that 2/3 of this footprint is coming from the supply chain. So medicines and chemicals and medical equipment are big contributers, non-medical equipment, so other things to run our buildings. But 2/3 are things that we as clinicians and hospital healthcare administrators have a lot of influence over. In fact, numerous studies have shown that 60 to 80% of healthcare's footprint is coming from the supply chain, and much of that is coming from upstream manufacturing. So that means if we can address the energy sources and also address, so upstream energy sources and also address downstream overconsumption. Those are important areas to target. So healthcare administrators and clinicians control which and how many of these things that we use. Manufacturers and regulators control embedded emissions and what actually goes to marketplace. And when we look at health system studies, and this isn't unique to healthcare, corporate social responsibility reporting, it's a similar problem. The supply chain, or what's known as Scope 3 emissions, tend to be poorly accounted for. And so why do we have consumed so much stuff in healthcare? So I talked about how obviously we approach healthcare from the lens of patient safety, meaning we want to do no harm. One of the fundamental things we have to do in healthcare is prevent healthcare-acquired infections. Healthcare-acquired infections are the most frequent adverse event in healthcare delivery worldwide. Hundreds of millions of patients affected globally each year, significant morbidity and mortality, and financial losses to health systems. So at the same time, we don't want to waste things if we contribute to an infection that increases care requirements, increases length of stay, increases drugs and devices and consumables. So it's everybody's interest to prevent healthcare-acquired infections. And in high-income nations, and Canada and the US included, 1/3 of ICU patients have at least one healthcare-acquired infection, and many have more than that. And so one of the problems with healthcare-acquired infections is that it's being used to justify this trend toward increasing reliance on single-use disposable devices and also drug waste. So for example, drug vials can come in multi-dose or single-dose vials. Those that are multi-dose vials, meaning they can be used on more than one patient, they have preservatives added to them to protect against bacterial growth from multiple punctures. But for example, in the US, there's been some concern for cross-contamination even in the multi-dose vials. So in clinical care areas, such as my area in perioperative services, we're not allowed to split those doses between patients, which is why you see the problem, as I've shown you with Hurricane Maria, where we have this large 30 ml vial, and we only need 1.4 ml, for example, 1.2 ml. Because of regulations around justifiably wanting to prevent infection, we are driving up waste. The question is that the appropriate solution to the problem? We really need to do root cause analysis. So why so much drug waste? So oversized vials. So even single dose vials, many of them are larger than are needed for a single patient. Regulatory complexity, I just gave an example of why there's a lot of drug waste, this concern and justifiable concern for contamination. We also over-prepare, so we set up and prepare too many medications that we need, and the drugs that we prepare, meaning we open the vials and we draw them up in syringes or put them in bags, their shelf life goes way down once we open them up. And so for all these reasons, we see a lot of drug waste. And I can tell you that there's been multiple studies that show in perioperative services that 30 to 80% of our drugs are routinely wasted. And it's the most drug intense area of the health system, of hospitals. And then insulin is a particular concern. So we are routinely wasting 97 to 99% of these vials in the operating room. I don't know if this has made any news in Canada, but in the US we've had out of control increase in prices for some of our drugs, and insulin being a big one, which has resulted in patients splitting their doses, reducing their doses because they can't afford them, and some people have actually died because of it. And at the same time, they're unsafely rationing their insulin. We're throwing away a lot of it. There was this important study that came out of the BMJ in 2016 that just looked at cancer drugs. Now, understandably, cancer drugs are among our most expensive, but that wasting cancer drugs cost $3 billion a year, and that was mostly attributed to oversized vials. So there's a lot of opportunity here to address drivers of waste. So I mentioned, and I'm going to talk a lot about single-use disposable devices now, which is a particular interest. So why are we seeing this? So there is this perception of lower costs because we just look at the procurement costs and not the handling costs. There's this impression of improved safety. Again, this concern for sterility and infection control, but there are very few studies. It's very hard to find studies doing head-to-head comparisons demonstrating that there's improved safety from an infection control perspective by using disposables. And obviously, things that are very cheap to manufacture and things that are very difficult to clean, for example, IV catheters, we're not going to try and reuse those and collect them. But we have to be very careful about our assumptions about improved safety for these devices. And we're seeing, obviously, a lot of trash. Most of the trash gets, in the US, gets incinerated. And so that liberates a lot of toxicants. Now we have waste to energy, and there are some systems to try and prevent a lot of these emissions, but it's still, solid waste is growing and it's a concern. So life cycle assessment is an engineering tool that we use to quantify emissions. And the reason why we do this is because if we're trying to make improvements, we want to know where to focus our improvements. Is it in manufacturing? It's in transportation? Is it disposable? And also, if we're going to do comparisons between products and processes, we can't just, look at what we throw away, which is what most people do. Let's look at, we're most struck by how much solid waste there is, but that may be the least of the problem. In fact, it could be the material extraction and the production that is creating the most pollution. So at every step of the way here, there are emissions. And again, so we have to consider the entire system to understand where to approach our improvements, and it's not always intuitive. So I said that, in terms of medical devices, a lot of the energy that goes into manufacturing is a big part of the problem. In the case of anesthetic gases, it's what we throw away because they're released directly to the atmosphere. So that's the biggest part of the problem. And so it's not intuitive. You have to really look at the whole cycle to understand. And we have to consider multiple environmental impacts. We're talking mostly about carbon dioxide emissions, but that's not the only category of concern. We have to be very careful we're not shifting the burden of one problem to another, and we have to prioritize what's most important. And so this tool is used to quantify metrics to help design and decision support. And so collaborate most commonly with Dr. Matthew Eckelman at Northeastern University to do these studies. And so getting back to this issue of infection control, it's important to understand that there are different risks of different types of devices. Not every device needs to be sterile. So critical items are things that contact normally sterile tissues. So surgical instruments that enter sterile body cavities, those instruments must be sterile. Semi-critical items contact mucous membranes. So those things, mucous membranes or non-intact skin, so those do not need to be sterile, but they do need to be high-level disinfected. So it's, they're not completely sterile, but they do kill the vast majority of the pathogens, the ones of concern. And non-critical items are the ones that contact only intact skin. So here's an example of a ultrasound probe. Examples of semi-critical devices I'm going to show you momentarily, things like laryngoscopes, so things that enter the mouth, or vaginal or anal cavities. Those don't need to be sterile. Those are very dirty areas of our body. Non-critical areas contact skin, so things like blood pressure cuffs. So those require intermediate or low-level disinfection. So that can be done at the point of care. This is an example of a chemical wipe. Critical and semi-critical items typically go down to the central sterilization supply department for reprocessing. So it requires more infrastructure. So I'm just going to give an example of one of our LCAs and why we did this. So this is an LCA of a reusable laryngoscope versus a disposable laryngoscope. This is used to safely place a breathing tube. The handle and the blade are considered differently. The blade, since it enters the mouth, I just told you that would constitute a semi-critical device. I also just told you that the handle, which is just touching skin, would constitute a non-critical device and just require low-level disinfection at the point of use. There was some concern that when you fold it, the tip touches the handle, and therefore there could be some concern for cross-contamination. And so there's a loophole in the regulations and concern around this, but where do you draw the line? So if something sterile touches something that's, non-sterile underneath, there could be cross-contamination, or, so it's touching something else that's non-sterile and so forth. So it could be taken, the argument could be taken ad absurdum, but nonetheless, there was a regulatory loophole that was driving the adoption of this single-use device, which is disassembled here. So this is again a stainless steel tongue blade, a plastic handle, 3 lithium batteries that would just be disposed of after one use. And so we did a LCA. And so this LCA, this is a description of the boundaries. So the single-use disposable one, we looked at the inputs from raw materials to production, to packaging, to use and eventual solid waste management. For the reusable, is a little bit more complex because we looked at different cleaning requirements. So I will say that the disposable, the options were to send the handle down to central sterilization supply department for a higher level of disinfection, or go to disposable. Those were the options. And just because it was simpler, most people were going to the disposable. They also tried to argue it was cheaper and more environmentally friendly. So we challenged that by doing the studies. So we looked at the entire, again, the entire life cycle, but in this case, we're looking at different modes of cleaning. So low level, high level disinfection, sterilization. We also included refurbishment as part of this analysis. And we looked at we looked at waste treatment impacts as well. So comparing the single-use disposable, and then for the reusable, it was rated for 4,000 uses. So it's 1/4,000th of the manufacturing of that and disposal of that device, and then a cleaning each time. So we also looked at costs. So I mentioned that a lot of cost analyses just look at the procurement costs. We also included refurbishment. We included labor to clean the devices, and also waste disposal fees. So an LCA and a LCC, a life cycle costing analysis. And just to briefly run through the results here, if you just kind of squint at this, some things that you notice is that the gray stands out. These are the disposable options, the blades and the handle separately, and then the different cleaning strategies. And then for the disposables, we looked at plastic and stainless steel models. Some takeaways include that for the disposable blades and the disposable handles, anywhere from 3 to 7 times the environmental, the greenhouse gas emissions. It was true for other emissions categories as well. And the other thing to take away here is that the red part here, that's the waste disposal. We assumed average US disposable mixes, so a fraction is recycled, a fraction is incinerated, a fraction is landfilled. We did an alternative scenario because people would say, well, we can recycle them, so it's not so bad. Well, it turns out that they're very complex to recycle. I showed you that piece, and only some components would be reclaimable. But for the sake of argument, we assumed 100% would be recyclable, and that's what this bar here is representing. So we cannot recycle our way out of this problem. Not that recycling isn't worth going after, but we certainly can't rely on it as a solution. And we did a similar cost analysis, and just squinting at this, basically the disposables increase the cost at our institution, where we do about 60,000 intubations a year in my department, increase the cost easily $700,000. And so, sorry, I don't know if I included the break-even analysis here, but basically what we found that both from a cost and an environmental perspective, that if you got at least 4 to, one of the arguments is, well, we use disposables because we lose the reusables, and therefore it's cheaper to go with the disposables. And we did a break-even analysis that on average showed that if you could get between 4 to 7 reuses, then it would be the same cost, roughly the same for cost and environmental emissions. And so for a device that's rated for 4,000 uses, if you can't get 4 to 7 reuses out of it before reusing it, I would argue that you need to retrain your staff and not simply switch to disposables. And well, I'll leave it there at that. There are other studies out there, including, and I bring this up because we're in the age of COVID now, reusable versus disposable textiles. This was actually a review because there have been several papers on this topic. And the disposable gowns, for example, 2 to 3 times the energy used, 2.5 to 3.3 times water, 7.5 times more solid waste. People are seeing a lot more solid waste, obviously, with COVID, and 2 to 3 times the emissions of the disposables versus the reusables. And something to keep in mind here, this is a study from Forbes McGain out of Australia, that where these studies are done matter. Obviously, the costs are going to vary by institution, and also energy inputs are going to vary by region. And so he did a study, similarly, where he found that if you were to do the same type of study In Europe, it would actually be even more favorable for reusables because they have a more renewable energy mix compared to the US. I apologize, I can't compare it to Canada, but this was from his paper. Versus in Australia, where they're very highly reliant on brown coal. In fact, some of his research found to be more favorable from a carbon perspective to rely on disposables. But the answer isn't let's use more disposables. It's let's get rid of brown coal. So I mentioned, so a lot of this driver is coming from concern from infection control. So this is an important historical work that basically, if you go back to around 1800, just as an example point in time, and you had a major operation like a limb amputation, you had about a 95% chance of getting an infection, about a 40% chance of dying from the procedure. And then along came germ theory, Semmelweis, Pasteur, Lister, and then anti-sepsis, aseptic technique caught on. And that's where you see the dramatic drop in infections and the dramatic increase in survival. And this other blip that you see here was the introduction of antibiosis into our routine surgical protocols, and which have been getting perfected over time. So now you have about a 5% chance of getting an infection from a major surgery, less than a 5% chance, I should say, and a greater than a 5% chance of survival. And so if we just blow up this part of the curve here as we're decreasing our infection rates, we're asymptotically approaching zero, and we're throwing more and more disposables at this problem, trying to prevent infections, and we're increasing this hidden or indirect disease burden, which heretofore has been ignored, and we say we cannot ignore it anymore. And so it really begs the question, is the goal of zero healthcare-acquired infections, is that realistic? And we really need to pay attention to what's happening here and try and strike the right balance. And importantly, causes of infections are multifactorial. So whether or not we wash our hands properly, patient health status, so patients are immunocompromised or have diabetes, these all factor into whether or not they get infections, the exposure site, the quantity and the virility of the organism and its inoculation. So there are multiple factors that go into infections, healthcare acquired infections. And importantly, we know the two most important things we have to do is, number one, we have to wash our hands more. And so the World Health Organization has a huge campaign around this, that even us in wealthy nations and the top institutions don't wash our hands enough. And patient health status. So we're not going to cure the problem of insufficient hand washing and diabetes and immunocompromised by throwing more and more disposables at the problem. So we really have to think more closely about this. And shifting to, the analogies with COVID, the problems with relying more and more on disposable goods is that our supply chain is global. And the virtue of doing this is that it reduces production costs by going to poorer nations where you can get cheaper labor. It also exports our pollution. We get our material, and so we just have to ask the question, is it just? We have just-in-time deliveries, so we only get supplies as we need them to decrease storage costs and device expirations. But there's also this problem of lack of transparency of the supplier risk. So at most, people might know who their direct suppliers are, but who are the suppliers of those suppliers and where are they getting their raw materials? And so it's a very complex supply chain. And so interruptions anywhere here can cause massive disruptions, as we've seen with COVID, and where most of our chemicals and also our PPE have been produced. And so this leaves us vulnerable, as we've seen, both from interruptions in manufacturing and transportation. And whether it's from COVID or climate change, we see, as I showed you with Hurricane Maria, it's the same risks. And so this sort of leaves us scratching our heads about why we're, that we need to rethink our reliance on disposable goods, both from a vulnerability perspective and also an environmental perspective. And this is has come to most attention, PPE through gowns and head coverings, and also, of course, N95 masks, where we've had to extend use and compromise. But these weren't the only supplies that were affected. Video laryngoscopes, which is a variety of the laryngoscope, the medical device I showed you, drugs for sedation, dialysis supplies. So all these things have been on shortage. And, really we have to ask the question, what is a disposable medical device? Well, it turns out that the single-use disposable, or SUD label, is an industry label. It's not a regulatory label. And now I'm quoting regulations from the US, but probably this is a similar story in Canada. But the SUD is an industry designation. It does not mean a device cannot be reused. What it means is that whomever cleans the device assumes the risk and the responsibility of the original manufacturer, meaning that if you clean it, you're responsible for whether or not it works. And so really this was very important in the history to manufacture obsolescence, because a lot of these equipment, hospitals did not want to own that risk, and so we started throwing them away. And so we have to ask the question next of what reprocessing means. So it refers to cleaning of a device, whether it's a reusable or a single-use disposable device. I just told you, doesn't mean it can't be cleaned or reused. Some things obviously doesn't make sense to clean. But reprocessing can refer to either in-house, what happens in the central sterilization supply department I mentioned to you, or it could be a third-party vendor. And it has come to refer to the third-party vendor. And there was pushback from industry as the original equipment manufacturers basically tried to say that medical device reprocessing was not safe. In the US, there was a government accountability office review that was commissioned by our Congress that basically found that there was no difference in safety risk in terms of device failures, because the companies that reprocess these are very careful to make sure that they can guarantee the safety. But unfortunately, only 2 to 3% of all approved devices are reprocessed in the US, and the market is even less developed in Canada and the US, but there's a big opportunity here. And so in the case of COVID, out of necessity, we've had to extend the use and figure out how to clean and reuse single-use disposable N95 respirators, as well as acquire reusables, and also in the case of impermeable gowns, or in this case, contact precaution gowns, we've had to figure out how to reserve them and reuse them out of necessity. But there are reusable options, and here's an example of a reusable and disposable type of the laryngoscope I showed you. All of these things have been in critical shortage with COVID. We've figured out how to safely reuse these. And really sort of begs the question of what's the difference between a reusable and disposable if we can reuse either and do it safely. Now, obviously, these single-use disposables have not been built for durability, and so they're not designed well to be cleaned and reused, but we can design things better. So in healthcare, we have traditionally, or recently, I should say, this the linear economy. I know you all have heard a lot about this today, meaning the take, make, waste economy, where we extract materials, we manufacture them, we use them, and then we throw them away. And the circular economy is this idea that we want to retain and reuse things as much as possible, reprocess them for reuse, repair and refurbish them, keep them in reuse, and obviously we need to reduce and repurpose materials as well. And the last thing here we want to do is recycle. That's not to say we shouldn't recycle, but it is the last thing we want to focus on. And importantly, is we need to redesign things for lasting, for durability. And so these are all principles of the circular economy to reduce, mostly to reduce the demand for and select materials that are less energy and polluting products and services. Again, we want to extend the life of and recover materials. We need to design out harmful emissions. And there's this concept of servitization, where rather than buying these products, where the companies are incentivized to make them non-durable, instead of buying the product, there's this model where you buy the service. And so that the company still retains ownership of the product, and therefore they are incentivized to make it durable and keep it in reuse. And linens are one example of that. There are other examples where you can buy lighting, you can buy lighting functions, you can buy MRI functions, you can buy copying machine functions. So you're not owning the machines, you're actually getting the function. And so as we're approaching the end here, the National Health Service, which you've also heard is really the global leader. They have the Climate Act of 2008 that committed them to draw down their emissions 45% by 2030 and 80% by 2050. That led to the creation of the Sustainable Development Unit, tasked with helping them specifically bring their NHS down to bring the emissions down. And in fact, they've extended their goal and now have a plan to get to net zero between 2040 and 2045. And you can see they're already dropping their emissions, and they have plans for all this. And I highly encourage you to go to their website and read more about it. And my understanding is that Canada, that you now have a commitment to also reach net zero, which means you also have the opportunity to go after resources to help support your health system in its transition. And so as we close here, the International Governmental Panel on Climate Change, a special report that came out in 2018, basically said we need to limit our warming to 1.5 degrees centigrade on average surface temperature rise. We're already at 1 degree centigrade. Business as usual is going to get us between 4 to 8 by the end of the century. Current policies are nowhere near where we need them to be, between 3.1 and 3.7 degrees, where we would be. Even the pledges of the climate Paris Accord don't get us to where we need to be, and our policies don't even get us to those pledges. And so really we need to aim to prevent the worst harm to civilization by the end of the century. We really need to aim for 1.5 degrees. And this is possible within the laws of chemistry and physics. It's just going to take unprecedented commitment by society to do that, which caused the IPCC co-chair, Deborah Roberts, to say that the next few years are probably the most important in all of human history. And the good news with COVID is that we've shown we can bring the international community together. We can make a difference. Obviously, we're quite fatigued, but it is possible. And the idea of flattening the curve, this idea is not to make COVID go away. We can't make COVID go away, not until there's a vaccine and we end it. But the whole movement to flatten the curve, the idea was by social distancing, by wearing masks, by doing appropriate hand hygiene and trying to minimize touching our faces. The idea is that we would slow down the spread, so that we don't exceed the healthcare system's capacity to replenish its resources, human and physical resources. And the same is true of climate change. We can't make it go away, but we can certainly slow down the procedure, slow down the process, and give society the time to adapt that it needs. And by comparison, 10 years compared to this past year with COVID is a very long time to make massive transitions. We've rapidly had to change our health system to deal with COVID. So 10 years seems a lot more doable, and it can be done in a way without shutting down the economy. We can actually support our economy and grow our economy. So where do we go from here? I don't know if I did that or you did that, but it's the last slide, I promise. The triple aim of healthcare, which is reducing, the most care for, the best care for the most patients at the least cost, this idea of value. Also now has to include environmental and social costs, not just financial. So we need to reduce environmental and social harms. In order to get there, we have to measure things. We have to quantify pollutants for all clinical activities, including our health systems. So we have to include environmental emissions in the total cost of ownership and part of decision making. And as you've heard others say today, we need to frame public health as a matter of patient safety, quality and value of care. And we need mandatory reporting and accountability, and in the US that's pay for performance. And I know I've gone over my time, but your organizers assured me we had some extra time, so please forgive me, and thank you for your attention.
Thank you so much, Dr. Sherman. That was incredible and very informative. I definitely learned a lot there. I guess the current situation is a little bit anxiety inducing, but I think there's also definitely lots of things we can do in the next little while. So in terms of time, actually, yes, we did actually a little over budgeted a little bit for the award ceremony section. So we do still have about 10 to 15 minutes for Q&A. And we have a first question already from Dr. Aviv Shachik. So as a health informatics researcher, I'm concerned about the potential impact of computers in health on the environmental energy consumption in terms of electronic waste, et cetera, especially with the growing use of AI. Do you have any insight on how we can address these issues?
Yeah, that's a great question. I really appreciate that. So I'd say, a few things, including we need to make sure that our data system, our data centers are powered in a renewable fashion, and obviously, overall clean up our energy system. In terms of electronics, we have to really pay attention to the manufactured obsolescence. I can tell you my own institution I'm seeing computers changing over so fast. It's just, you know, and new capital equipment changing over quite fast. And I think it's you know, trying to keep up with the latest and greatest, and not necessarily that it's benefiting any outcomes. So we have to be careful of that. We have to, there's a whole right to repair movement. So, you know, manufactured obsolescence is a big problem. I mentioned this also applies to electronics. So we have to make sure that we are working into our agreements that we have the ability to repair things. The concept of servitization I mentioned. So perhaps we're not buying the electronics, we're buying the service, and the company retains ownership of the electronics and the equipment. So that way they're incentivized to keep materials in use. And also when we do our contracts, we can do, there are environmentally preferable contracts. We can mandate that our vendors take equipment back and handle in a certified, responsible way to repurpose where possible and to dispose of in the safest manner. There's no perfect solution there, but there is a lot of opportunity for us to improve.
I suddenly was muted. If anyone else has any other questions, please type them into the chat box or the Q&A section. Or you can also raise a hand.
Sorry, I see one in the chat. If so, I'll toggle back and forth between the chat and Q&A. So I see a question from Dr. Laporte that asks a question like, what my sense is of why the UK was able to mobilize and going on these this initiative in their health system. So firstly, they had their, as I mentioned, the Climate Act of 2008 that committed their governmental organizations, including healthcare, to draw down their emissions. And so that led to the creation of the Sustainable Development Unit. And so they have the longest government-sponsored metrics that have been occurring for the past 10 years. What's new now is that they're actually going to do a lot with the implementation, so getting to net zero. So I was part of a group that was commissioned to evaluate their work so far and to help develop a plan to help them get to net zero. And really it came from the top down. So Simon Stevens, you know, very high up in the NHS, basically made a decision that we're going to get to net zero, and was very proud to wanting to be the first declaration. And so it became, you know, sort of a competitive pride to say we're going to get there first. So it really came both from policy and from leadership. And even despite the COVID crisis, they're still moving forward. So, you know, we're very fortunate we have that exemplar.
Danielle also has another question. She's asking, what do you see as the key roles and next steps for trainees in this movement?
For trainees, that's a great question. So obviously there are going to be differences between specialties, but I think importantly, I know all of you have been doing projects related to this area. You know, this idea of doing quality improvement projects and addressing issues of waste and, looking for opportunities to collaborate and do studies on environmental emissions, right? Because there are two general categories of areas that we need to approach. One is reducing waste, which is very complicated to address. The other is to do environmentally preferable practices. So they're two separate things, right? And so the challenge with environmentally preferable practices is that there's very limited information so far, which is why it's easier to go after waste as lowest hanging fruit. Excuse me. And at the same time, it's easy to get enlistment around waste reduction because there's also cost savings at the same time. So for trainees, I think it's important to try and get involved with these projects. I think it's important to ask the questions. And I think it's important to challenge the status quo. So in my own area of anesthesia, you know, there's a lot of practices that we do that are habitual. So for example, when I started, we would open up, you know, 3 different endotracheal tubes, stylet them all, have 2 different size laryngoscopes open, draw multiple drugs just in case we needed them. And this was just this is just standard of how we did things. And now challenging those things, you know, the hard part is that you have to please your attending. And, you know, every day maybe a different attending with different practices. And so it's very challenging as a trainee, but to push back on that. And for those who are more in the primary care specialties, who really have to look to more options to really focus more on self-care and preventive care. And that's also true of us as providers, and try to increase access and capacity to do self-care, and to try and change the reliance on disease care, pills, surgeries, and so forth as the solution.
Mm-hmm. We have one more question from Dr. Fiona Miller. Do you find that the agenda for mitigation in healthcare is motivating? Some stakeholders think healthcare is too small to move the needle. How do you respond to these challenges?
That's interesting. I haven't received that question before. I never thought of it because, I mean, I just told you that healthcare is 10% of the global economy. So everything we do in healthcare is related to virtually every other material industry. So if we can move the needle on healthcare, we can really help push the economy in a more sustainable fashion. So I would not, I would not think we're small. The important thing is that we have to combine our purchasing power. So that's where nations like the UK and in the Canada, I see the comment that it is easier in the UK because they're more centralized. That's true, but they do have a lot more independent capacity than one would know by the reports that we read. So, but they're certainly not as federalized, or more regionalized as we see in Canada and the US. So they definitely have that advantage. But combined, we have a lot of purchasing power. And as I said earlier, health professionals touch every single patient. We have a lot of leverage in public policy as well. So I think we have a lot of opportunity to make a difference. And the place to start is where, we have our mission to first do no harm.
Mm-hmm. For sure. Are there any other questions? Okay. So I think we'll end there. Thank you so much, Dr. Sherman, for joining us.
Thank you, and thank you for allowing me to go over time. It's only because you told me I had permission that I took that time.
Absolutely, absolutely.
Thank you.
Thank you so much, Dr. Sherman.
Mm-hmm. Now we're going to move on to the award ceremony portion of our afternoon, and I will be sharing my screen to show our award ceremony video.
Good afternoon, ladies and gentlemen. My name is Beth Chu, and this is my husband, Junbi Chu. We are honored to be here to share some memory with you about our son, Jack Van Chu. About 2.5 years ago, Jack was unexpectedly taken away from us. He was only 53-year-old. In the prime of his life, leaving behind his wife, teenage son, and extended family both at ISIS and Sunnybrook. Jack was born in Taiwan and immigrated with us at the age of 2 to Canada, settled in Kingston, Ontario. Jack always showed a great passion for science from a very young age, participating in science fair at the local, provincial, and national levels. He also very interested in computers when they were first being introduced to schools and households back then, the days when we used punch card and the floppy disk. He graduated from medical school at the University of Western Ontario at the age of 23. Did his residency and master's in clinical epidemiology at the University of Toronto, and his PhD in health policy at Harvard University. His whole professional career was at the University of Toronto, where he worked clinically in internal medicine and then cardiology at the Sunnybrook. And his research was centered around cardiovascular health service research. Jack is no longer with us, but his love for life, quest for knowledge, relentless effort to find solutions to make this world a better place is well and alive in the bigger community of the medical research world. We are sure Jeff will appreciate that this award of excellence has been named in his memory. He will join us in congratulating and encouraging the recipient of this award to continue forging ahead for a greater good. We wish the award winners all the best.
It is a great pleasure to be here today to see so many of excellent young researchers follow the same step like Jack. Jack was a researcher when he was a very young student in the primary school. His achievement is well known, and his enthusiasm is very much present here. And we're delighted to see he is not alone. And we wish you all the best for this great country, for the great future. And your caring will be very, we will always be very proud of you for the devotion you have made. Congratulations for your achievement. I wish you have a good time.
The Claire Bombardier Award is selected by the Clinical Epidemiology Executive Committee and is awarded to the most promising student in the clinical epidemiology and healthcare research concentration. This year, the winner at the master's level is Amanda Hurd, at the PhD gold level is Maria Cusimano, and at the PhD platinum level is Fahima Dosa. Congratulations to all the winners.
It is my pleasure to present the IHPME GSU Outstanding Leadership Award. This award was created in 2020 with the generous support of the IHPME department and recognizes the contributions of GSU executive members in improving the IHPME student experience. I am pleased to have had the opportunity to work with both of these very deserving candidates. The first recipient of this award contributed to multiple roles on the GSU, including as a health and wellness lead in 2019-2020. He recruited and trained a number of peer-to-peer navigators, led various initiatives including Some Days Are Like This and a health and wellness hashtag contest, and secured over $2,000 in funding for the inaugural IHPME Mental Health Day. The second recipient is someone who I had the honor and privilege to lead the GSU with. She served as vice president in 2019-2020 and was the right and left hand I never knew I needed. Her long list of accomplishments includes modernizing the GSU by reviving the GSU website, taking a lead role in organizing a variety of key events and activities, including orientation, and taking a lead role in the alumni mentorship program prior to her tenure as vice president. This past year, she also led the Randomized Coffee Trials Initiative. When she wasn't planning events and activities, she offered her support to other executives, including by providing feedback on grant applications. Most recently, she found an innovative way to share results from our student feedback survey by empowering students and faculty with data that could be summarized and analyzed in their own way. Perhaps what is most inspiring is her collaborative leadership approach, her can-do attitude, and her commitment to support and raise others up along the way. Please join me in congratulating both Elzar Sipin and Liria Sequeira on their achievements and as the inaugural recipients of the IHPME GSU Outstanding Leadership Award.
I'm very pleased to present the 7th annual Kevin J. Leonard Award to Beth Gerritsen, candidate for the Master of Health Informatics. A primary care nurse practitioner for the past decade and currently Associate Clinical Lead Digital Health for the Hamilton Family Health Team, Beth became the first clinician to implement online appointment scheduling and secure messaging with her patients. Technology has enabled Beth's patients to reach out to her when they need to connect. The connection works both ways as Beth reaches out to patients who struggle to check in. I speak from experience of the immeasurable value and appreciation to be able to reach out to the system and confidently know you will receive a timely response back. Beth's MHI capstone project is entitled Axe the Facts. And as I told Beth when we spoke earlier this year, you had me at Axe the Facts. Beth's central argument for axing the facts is that the fax leaves the patient out of the circle of care, as they don't know whether a fax has been sent or not on their behalf. Beth describes a project as daunting, but the COVID-19 pandemic has influenced system leaders and their motivation for change. In September, Beth met with senior provincial leadership in digital strategy, and she is now wrapping up her capstone report. Beth's endpoint of Axe the Facts is to template the processes and procedures required to achieve this goal and to leverage lessons learned to inform subsequent digital technologies and innovations in healthcare. Kevin embraced challenges and always moved full speed ahead to confront them and make change. Along with sharing Kevin's belief of patients as partners in their healthcare, I see the same passion and drive in Beth, who is bold in her pronouncements and declarations, and also determined to meet challenges and make change, with none greater than Axe the Facts. I have every confidence that Beth will succeed in this mission and will continue to bring her energy and determination to advance patient-centered care in the years ahead. Congratulations, Beth, on being named the 2020 recipient of the Kevin J. Leonard Award.
The Ted Goldberg Award is an award for academic excellence and promise for doctoral candidates in health services research. The 2020 winner of the Ted Goldberg Award is Arlinda Rucco. Congratulations, Arlinda.
I am presenting the Thomas and Edna Naylor Memorial Award on behalf of the Naylor family. And here's a brief message from Dr. David Naylor. First, some background. Thomas and Edna Naylor were children of immigrants who reached university age during the Great Depression. Neither they nor their siblings had a chance to complete any degrees, but my father and mother strongly believed in higher education. Somehow, all 4 of their children ended up with doctoral degrees and have taught at Canadian universities. This annual award acknowledges and memorializes their subtle but effective brainwashing. It's been a very turbulent year on many fronts, but as we all know, the biggest disruption and most unwelcome surprise has come in the form of a novel coronavirus and a terrible pandemic. I'm grateful to this year's selection committee for persevering and choosing such a deserving recipient. More than ever, there is an acute need for excellent health research scholarship that bridges disciplines and offers original and relevant insights. In that regard, I want to very warmly congratulate Tanya Laser for her impressive body of published work and wish her every success in the years ahead. The Comparative Health System Award in honor of Les Bowen is given to an IHPME student who has shown outstanding leadership and made the most significant contributions in the field of health policy. The 2019 winner is Calvin Cook, and the 2020 winner is Dina Bayuni. Congratulations.
On behalf of Dr. Rhonda Cockrell, I am very pleased to present the Rhonda Cockrell Award for incoming IHPME research stream students. Congratulations to Dr. Waqas Khan on his receipt of the Rhonda Cockrell Award for incoming IHPME research stream students. Dr. Khan is an impressive young scholar who has already made many contributions to health services research. He is starting doctoral studies in health services research, and I wish him every success in his studies and future career. The Esther Wall Award of Excellence in Gerontology is an award for students who have provided outstanding leadership and made the most significant contributions in the field of geriatrics, gerontology, or long-term care. Ms. Esther Wall was a healthcare leader, strategist, consultant, and mentor dedicated to creating a warm, welcoming, and respectful place for seniors. She was an IHPME graduate of the Health Administration Program, 1978, and tutored in its health policy classes for many years. In the last 20 years of her career, Ms. Esther Wall was the executive director of the Bernard Batel Center, a place of learning and wellness that empowers seniors to lead active, creative, and healthy lifestyles in a Jewish environment. This year's winner of the Esther Wall Award of Excellence in Gerontology is Manisha Prasad. Congratulations.
Health Equity and Social Justice Award in honor of Diana Moser is given to an outstanding student at IHPME whose work is guided by the goal of health equity and social justice. The winner exemplifies the ideals and principles that Diana characterized through her career and personal life. This year's winner is Nazmi Masoudi. Congratulations.
We also have a number of Research Day presentation awards. For the morning concurrent session, The Future is Now, Exploring Advances in Healthcare and Health Research Methods, the winner is Samantha Young. For Saving for a Rainy Day, Allocating Health System Resources, the winner is Lauren Ramsey. For Teamwork Makes the Dream Work, Engaging Patients, Community Stakeholders, and Knowledge Users, the winner is Andrea Duncan. The afternoon concurrent sessions, with the topic, A Bird's Eye View of Public Health and Health Services, the winner is Danielle Toccolino. For the topic, Getting Comfortable with Being Uncomfortable, Acknowledging Systemic Barriers that Produce Health Inequities, the winner is Denise Webb. For the topic, An Ounce of Prevention is Worth a Pound of Cure, Improving Quality in Healthcare, the winner is Laura Schutz. Now we'd like to present the Research Day Poster Awards. The G.P. Rosenfeld Poster Award for the Best Master of Health Science or Master of Health Informatics poster goes to Hassan Mu. The IHPME GSU Poster Award for Best Masters in HSR or Quality Improvement in Patient Safety poster goes to Natasha Jawa.
The Eugene Veda Poster Award for the Best PhD in HSR poster goes to Micah DeVries.
The IHPME GSU Poster Award for the Best Masters in Clinepi poster goes to Sarah Smith.
The Jillian Hawker Poster Award for the Best PhD in Clinical Epidemiology poster goes to Manish Sood.
Maureen Dixon Memorial Award for the Best Oral Presentation or Poster Presentation related to research on community-based consumer or caregiver group goes to Laura Schutz.
The winner of the Robert Duff Barron Award for the Best Oral Presentation or Poster related to public health policy or most closely related academic field is Danielle Toccolino.
Congrats to all the winners, and that brings us to the end of Research Day 2020. On behalf of the entire planning committee, thank you so much for joining us. Take care, and we hope to see everyone again soon.